Bismillah ar-Rahman ar-Rahim. We have today a nice case, which is one of the lessons we learned from Dr. Javier Moreno. This is a 35-year-old man who had atrial septal defect for which he received surgical closure at the age of 5 years. Then a few years ago, he started to have his palpitation after surgery by about 10 years, 20 years. And his ECG showed right bundle, underlying right bundle, and his tachycardia, we diagnosed it as atrial flutter. Atrial flutter, we had to know how big his atrium is. As you can see from this echo running on the patient now, the right atrium is huge dilated. This is a patch, and the right ventricle is normal, is within normal. So we decided to do him radiofrequency catheter ablation and to see what this flutter is. We could not have enough sponsor. This is donation case, so we could not get enough money to get 3D mapping. So we decided to use the technique of entrainment and post-pacing interval to localize the site. The common sites would be cavotricuspid isthmus or any flutter related to this scar. So we know that the scar is in the right atrium, and the cavotricuspid isthmus will be related to the CS. So we decided to do this mapping, post-pacing interval, and keda. I asked Rania to start doing this. We had the patient in the tachycardia. هات من الأول. Okay. This is the tachycardia ECG get at 25 speed. Okay. The patient came to the clinic yesterday in tachycardia, so we decided not to terminate, but we gave him small amount of beta blocker Inderal to slow down his ventricular rate, as his rate was 190. Rania, from the ECG, you made diagnosis that it could be flutter in the right side or in the left side?
It looks like it's a flutter from the right side. We have flutter waves positive in inferior leads, and in V1 it's negative, so it resembles the clockwise typical clockwise CTI dependent atrial flutter, but there is a baseline between the flutter waves, so it might suggest it's an atypical flutter. Also, the history of the patient, the ESD patient who had hugely dilated and surgical closure of an ESD. So this raises the presumption of having a typical flutter rather than a CTI-dependent atrial flutter. So we went in with our catheters, trying to verify if it's a CTI-dependent atrial flutter or atypical around the scar of the atriotomy.
We decided to put a decapolar catheter on the right atrium and another decapolar in the CS in order to map all the right atrium and to help us doing entrainment and measurements of or localizing the isthmus of this tachycardia. This is the intracardiac. هات الانتراكاردياك تاني. لا هات اللي هو السرعة أقل. This is the intracardiac. As we see the white, of course, limb leads 1, AVF V1 showing right bundle, which this young man has, and then the right atrial catheter from 1 to 910, and the CS catheter from distal to proximal, and the his catheter. So we had 2-to-1 and sometimes 1-to-1 conduction, as you can see. And the activation, mainly Rania, we can look at the floor to see. The CS1-2 is far away, صح? Yeah. The earliest will be the right atrium. If we look early and late, this shouldn't be like this. But however, this tachycardia is running from the right atrium and to the left atrium. As you can see that the CS all signals are at the same time, so they are simultaneous, meaning that they are looking at the activation is reaching them مع بعض. And the his catheter, maybe the A is before this, it is in the RV. Okay, so we can look at some fluoro. اديني fluoro من الصور. Okay, after that we can show you the fluoro. Then what you did, Rania?
First of all, we looked at the activation of the coronary sinus. At first it was simultaneous all together. We tried to withdraw it a little bit because it's was way inside the coronary sinus, and when we withdrew it a little bit, it showed somehow concentric activation of the coronary sinus catheter. This means that it's most probably right atrial flutter, or related to the septum, whether the right side of the septum or the left side of the septum. The activation, it's not perimitral, so it excludes perimitral flutter. When we place the other decapolar catheter in the around the tricuspid annulus, mainly mapping the lateral wall right atrium, the activation also of the right atrial catheter was also simultaneous. When we measured the right atrial activation, or the activation right atrial activation from the distal coronary sinus, from distal right atrial catheter to the proximal coronary sinus, it only occupied less than 50% of the tachycardia cycle length, and this excludes the idea of a CTI-dependent atrial flutter. We started to do entrainment mapping. We started with entrainment mapping, as Dr. Musallami is showing us here, from proximal CS, and the PPI was very long, and there was change in the activation sequence on the decapolar catheter, right atrial catheter. Okay. Then we moved to entrainment from the distal right atrial catheter, or decapolar catheter, and it showed a nice PPI. The difference was around 15 or 20 milliseconds, and there was a subtle change in the sequence of activation during entrainment, so it was some sort of a manifest entrainment. Then we entrained from right atrial catheter 3 and 4, and we had a concealed entrainment. The PPI was very good, and the sequence of activation didn't change. So we moved in with our ablation catheter, and we entrained from the CTI. Where's the entrainment from the CTI?
So you introduced the ablation catheter, and you took an irrigated tip catheter?
Yes, an irrigated tip catheter, bidirectional catheter, along a non-deflectable sheet.
Within a scar or something?
Yes, okay. Yes, to maintain the stability of the catheter.
With entrainment?
No, this is not from the CTI. Where's the entrainment from the CTI? This is from the lateral right atrial wall. Do you have the one with the...
Okay.
From the ablation catheter. Entrainment from an ablation catheter? No, this is not from the CTI.
From ablation.
From ablation, but we weren't the CTI.
Okay. The CTI, you can make sure that it is not, because you...
It was very long PPI.
CS 9 and 10, and was very long.
It was very long, manifest fusion.
After that, you went to the ablation catheter, and
yeah,
it was not recorded here. Anyway, so here, go to the first segment. You were here in the...
A lateral right atrium, close to the atriotomy scar. We had a fractionated potential on the ablation catheter here, so we were close to the distal end, or the lower end of the atriotomy scar. We had fractionated electrograms, and we entrained. We had very nice PPI and concealed entrainment.
Regarding concealed and manifest entrainment, this means that the atrial signal during pacing has not changed from the atrial signal during the tachycardia, and you have to make sure that you are capturing, and you show us here now that the cycle length of pacing is equal to this is the pacing cycle length, yes, go خدها بقى بالنص, take it from كده and go to the green.
The green coronary sinus.
Make sure that you are...
It's the same.
So you make sure that you are in training, you make sure that you did concealed entrainment, and the PPI. You're lucky that the signal is beautiful signal.
Yes.
As Dr. Molina said, you have to make the magnification.
Yeah, we increased the gains, and when we were there, we were moving our catheter there. We interrupted the tachycardia. We terminated the tachycardia, but we terminated by induction of PECs.
Okay.
a couple of PECs terminated the tachycardia from that site. So we decided that we are going to ablate from there because our electrograms was very nice with showing fractionated electrograms, not double potentials. Also, we entrained before from this site and had nice entrainment, concealed entrainment. So we decided to ablate there, and we dragged the ablation. After we ablated there, we dragged the ablation down to the IVC to connect the atriotomy scar to the IVC. And then we did the post-ablation study using drug provocation, isoprotrinol, and using burst spacing and programmed electrical stimulation using single and double extra stimuli, and there was no induction of the tachycardia.
You went to aggressive protocol. Now we'll see the fluoro. Of course, we didn't, as I said, we could not get 3D mapping sponsoring this case, so we decided to do the old electrophysiology. From the beginning,
It was in the in the CTI, and we entrained from there, and it was very long.
We'll show you the catheter placement. This is the decapolar catheter in the lateral of the right atrium, another decapolar catheter into the CS, and here this catheter is in the right ventricle. You can imagine how big his right atrium is and where the right ventricle is hugely displaced. And now this is the cavotricuspid isthmus will be in this area. So, and these are the stitches of the sternotomy which was done when he was 5 years. Now he's 35. That was 30 years ago. So this is the site of not good site. As you see, 1 and 2 in the quadripolar catheter had a relatively good but made manifest entrainment. Here in the 3-4, there was concealed entrainment and very short PPI, so we were in the circuit. So, and you got here the fractionation and not double potential, you said, because double potential means you are in the stitching out in the suture line of atriotomy. So when you touched this, you had atrial premature beats
and the tachycardia terminated. So we decided to start ablating from there because we know that this is a site has a very good concealed entrainment. We started ablation from there, and after we ablated there, we went down. We tried to connect the atriotomy scar to the IVC.
So you made an
imaginary line. Yes.
Without 3D.
Without 3D.
When you were conventional in your beginning of electrophysiology training and you go to 3D, the basic electrophysiology predominates. So you had this line going down from as if you are doing cavotricuspid, but on very lateral line.
Yes. Yes.
So she went from here down to the IVC. Had other pictures. Yes. As you can see, the tachycardia has stopped. Yeah. Again, more pictures.
No.
Okay, so these were the fluoro pictures of the case. As you can see, this is a running case at the lab. He's in sinus rhythm. He has underlying right bundle and left axis. We hope we'll give him anticoagulation. Okay. Best. Thank you very much.